Bring your screen slightly forwards.
Is that right?
Mhm.
Can you all
Yeah.
see it?
Yeah.
Okay, so like we said, the possible causes and high risk in children in neonatal ICU, and also infections. We forget about infections. Okay, and congenital malformations in children. This all can cause single-sided deafness. Infection, which is the most common infection, however, which is the most common infection to cause hearing loss in children.
Influenza.
Sorry.
Yeah. Sudden idiopathic SNHL is the HSV herpes infection.
Herpes simplex, okay. Other
Mumps.
most common than herpes simplex.
Mumps.
CMV. CMV is the most common infection. Absent or hypoplastic cochlear nerve. Okay, how are you gonna manage that before we jump? Absent or hypoplastic cochlear nerve.
ABI.
Yeah, those are the same implants. Okay, craniofacial abnormalities, ICU, like we talked about it, and complication of prematurity. Possible causes in adults, how are you gonna categorize it? So in the exam, you have to categorize the like classification. So you don't say trauma, blah, blah, blah. You have to make a system when you answer this question. Any proposed system, how are you gonna answer this question?
And we infective or
Other
traumatic
than
or
that,
neoplastic.
okay, you
Is
can
it sudden or is it long term?
you can classify as that easy, conductive, and sensorineural mix. And then you put the causes conductive, infective, traumatic, da 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 da, sensorineural, infective, traumatic, da, 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 and mixed. So yeah, conductive causes like conductive, single-sided,
Yes, or conductive
infection, trauma,
Eustachian tube.
eustachian tube dysfunction, plenty of causes that attacks media.
Otosclerosis.
Otosclerosis, a lot of things that can cause conductive. Sensorineural, single-sided,
Sudden sensorineural hearing loss.
sudden hearing loss, vascular trauma causing sensorineural hearing loss, stroke, acoustic neuroma, all these things, and mix any combination of both. Yeah. History, what we're gonna ask in the history?
Origin, duration, problems.
Exactly. And otological history, the 5 symptoms. What are you gonna ask about otological symptoms?
Pain, discharge, because hearing is there, tinnitus, dizziness, and
You said hearing loss, discharge, tinnitus, dizziness.
facial function we need to.
Okay. Still one left. Pain. Pain. This is the 5 otological manifestations, and the facial symptoms. Okay. You asked about the past and history because they had trauma. Trauma, previous operations, all these things. You ask about prenatal history in children, if they're in ICU or delivery, trauma during delivery. All these things is like straightforward for you. Comorbidities, diabetes, hypertension can cause a stroke and sudden hearing loss. It's not social history, they're smokers. Syphilis. Okay, so syphilis, be careful because of many years, and syphilis almost the same presentation. So be careful of that. Okay.
How prevalent is it?
Yeah,
How prevalent is it now?
It's on the rise because
Is
of
it?
Viagra, isn't it?
Okay. I didn't know that.
Yeah, the older people. who are in
Yeah, so
hospital
I've
and
tried
have
to.
syphilis are now having sex again
Okay.
because of Viagra and spreading it around. Very sorry, but it's true.
I couldn't
What did you
I thought it was.
What did you? We're talking about syphilis and Viagra. This is recorded.
Oh, Miss Lawrence agree with me.
Okay. So yeah, syphilis can present as Meniere's disease, to be careful of that. Okay, so ask about the social history and then be embarrassed. Do you have sexual intercourse, unprotected sexual intercourse or behavior? So, can be asked. Family history because of genetic. Examination wise, you're gonna examine. What are you gonna examine in hearing loss patients with hearing loss? What examination you gonna do?
Do a full head and neck.
Full head and neck examination. You don't like when you say full head and neck examination in the exam. Okay, so I will direct my examination into this, and then I'll do So ear examination, okay, you're gonna full otoscopic examination. What else in the ear examination? Everyone forget that when in the course, everyone forgot.
Check their mouth side and then check.
Okay. What else in the
Tuning fork.
tuning fork? Everyone. And in the exam, I swear to God, they were hiding the tuning fork underneath the table. And they said, "What else are you gonna do?" I said, "Tuning fork," and they then bring the tuning fork from underneath the table to me. It's like, seriously. I didn't. I said in the ideal world, because I can't see the tuning fork on the table. In the ideal world, I will do a tuning fork test, and then they brought it from underneath the table and said, "Okay, you can do the tuning fork test now." So
If not, they'll fail perhaps, isn't it?
of course. What else? Everyone forgets.
Civilization.
Huh?
Civilization to see the drum mobility.
Not really. What else?
What are your, I mean, other cranial nerves?
Okay, that's okay, but what else in the ear examination? Everyone forget that, and we don't do it in
You mean the
usual
facial nerve?
patient interview. You have to do that. But
Yeah.
else, what else? Pre-field testing. They expect you to do pre-field
Really?
testing, and they
Okay.
ask me to do a pre-field testing, and you have to know the numbers
Okay.
away, near, away and near, and how much defects that you will have. So
Okay.
pre-field testing. Don't forget the pre-field testing. Okay, and I said in the ideal world I will do a pre-field testing, and they said do it. Yeah. And the neck examination, don't forget to do FNE, because we just so this 2 cases of suspected nasopharyngeal carcinoma with middle ear effusion. Yeah, any patients above 40 with unilateral effusion is nasopharyngeal carcinoma broken otherwise. Okay, and direct examination, like we said. Investigation wise in children, what are you gonna do in children? Investigation in children with a single-sided deafness, or what's the first thing? Neonates. What are you gonna? How are you gonna?
Units
Yes,
will screen with
With what?
OE, and then go for a para
ABR.
ABR.
So oral acoustic emission, that's how the device looks like. He asked that question. You show you and ask what is that. So oral acoustic emission, and you pass if you get 3 out of 5. So you try 5 trials and you pass 3 out of 5. You know basically how it works, right? Detects the autoacoustic emissions coming from which cells? Outer hair cells. Okay, and then the most sophisticated is the ABR. Do you know why children can be done while sleeping, while adults you need general anesthesia? Because in children, ABR is basically averaging. So you will give a lot of signals and you average the brain um, activity, and it's average. Okay, so in children, they don't have much myogenic potentials. They don't move, they don't have much dreams like us. So you can easily detect which signals coming from auditory stimulation. While for adults, if any movement, the myogenic potential will mask the auditory potential. So you had to put them to sleep, like general anesthesia, to be able to eliminate the myogenic activity in the brain and detect just the acoustic one. Okay, other test in children less than 6 months. How you test children less than 6 months? Exactly. You started in behavior testing is the one other one. Other one, what else you can do? Children less than 6 months.
You can
Tympanometry.
Yeah.
Yeah. Tympanometry. It's can be done. Tympanometry. And then 6 months to 2 years, what you gonna do?
Visual.
Visual reinforcement audiometry. They ask you about the visual reinforcement audiometry. So remember, it's 2 examiners. Let me remove. It's 2 examiners. One is sitting with a child, and one behind the window.
Okay.
So the one behind the window is the one rating the hearing, not the one with the child. Whenever the child look to the sorts of sounds, they will be showing above it. And the trick is that you need to check that the child can do 2 things, like 2 orders. Okay, listening to the sound and moving his head. So you have to tell them, I will check that his spines are fine and he can sit properly. So in child like craniofacial abnormality, Down syndrome, you can't do that. Okay, and children with learning disabilities, you can't follow 2 order command. You can't do that. Okay. Other investigations, play audiometry from from almost 5 years, to 2 to 5 years. and pure tone audiometry at age 4 or 5 years. So in the course, I don't know, a lot of the examiners don't know about the audiological symbols. Yeah, and it's confusing because in UK they have symbols and in the US they have different symbols, and sometimes they are confusing. Okay, so the right and the left, this is like masked, but if they put you these things, sorry, this is unmasked, and if they do these things, it means it has been masked. So if they cross it, it means it totally changed after masking. Okay, if they put like a half circle, it means it's the same after masking. Okay, this is the unmasked bone conduction and the masked bone conduction, and it's impossible to get masked bone conduction better than air conduction. It will never happen. That's one of my exam questions. I said maybe the patient was not focusing, but this can't happen. Masked bone conduction better than masked air conduction. Okay. The unmasked, yeah, the unmasked. When you ask you the unmasked bone conduction, which ear it points to?
The better ear.
The better ear. The better ear gives you the masked bone, unmasked bone conduction. Okay. And this is one of like non-organic hearing loss. This is the American symbol. I put this one to show the American symbols. So this is unmasked. This is unmasked American. Yeah, and this is the same masked American. Okay, and the air conduction mask they put the triangles. It's really confusing. Yeah. Anyhow, treatment wise. Okay. So for children, you can start with cross hearing aid. And when we done a study over in Oxford about the children over 18 years, which is the most common used modality to help children with single-sided deafness, cross aid. Okay, and you know how it works. Transmit the signal from one ear to another by Bluetooth, and if it's augmenting the other ear, it will be called what? If it's augmenting as well. Guys, if the cross is augmenting the other ear, what's going to be called? I was asking the question. I said, okay, they know it, but it's just like let's just like throw it and see what the bicross. Bicross. If it's augmenting the other ear as well, it's bicross. So if it's transmitting the signal from the bad ear to the good ear, it's a cross. If it's also augmenting the other ear, it's gonna be bicross. Okay. So this is the most common used one, and it's basically to avoid the head shadow effect. We have a head shadow for air conduction around 50 decibel-ish. Okay, if someone that can't hear from one ear, all these sounds can't cross. But with bone conduction, you don't have air shadow at all. Okay, I'm talking too fast. Just slow me down because there's a lot of information. You get now the bone conduction on a Baha on a soft pad. It's also commonly used in children. Okay. Usually we start with a trial of a Baha on a soft band. If they get benefit from it, we can switch into bone anchored hearing aid. Okay. Anyone saw the bone arc? So the Baha is like on the glasses. Other than being on a soft band, you wear it on a glasses. And of course, it's not going to augment much because you need a contact. The skin dampen around 10 to 15 decibel. Okay, so with the bone anchored hearing aid, you avoid that 10 to 15 decibel reduction in the sound amplification. Okay, so if the child doesn't need much amplification, you don't need that. I think there's a missing slide, which I don't know what's happening with it. Okay. Normal conventional hearing aid can be another option. Okay, a lot of children with single-sided deafness will use hearing aid. Okay, it's the first modality, and what kind of hearing aid is that? Because I kept asking candidates and they don't know. Can you all see it?
Yeah.
Okay, what kind of hearing aid is that? Behind the ear, which type?
And I love the digital earbuds.
No,
Is
behind, they're all digital. No one use manual anymore.
Yeah.
What kind of behind the ear this one? How many types of behind the ear?
conduction.
I mean, are you talking about the ear mold?
Ear mold. So we have the
vented
custom fit mold.
mold or
Exactly. And the vented mold or the open fit mold.
Yeah.
No one was like answering this question. You have to know the difference because custom mold will totally block the ear, so you get more amplification, like severe or profound. You never see a severe or profound with open fit mold ventilation. It can't happen because sounds will escape from it. Okay, and it can cause feedback. They need much gain. Anyone do you know what gain means? Gain. Difference between the sound going into the hearing aid and the sound coming out from the hearing aid. So the people with severe or profound hearing loss, they need much gain. And with increasing gain, there's a high risk of feedback. Feedback means the sound goes back into the hearing aid, like you put a microphone in front of the speaker and get squeak. So you need the custom fit mold to keep all the sounds in the ear. Open fit mold, if you're like a moderate hearing loss, you don't need that much gain. So this is custom fit mold, and child with a sensory neural hearing loss will need that. Okay. What is that? Cochlear implants. Okay. Bilateral in children. If they fit the criteria and they're happy, we proceed with cochlear implants. And some children with single-sided deafness, we just like behavioral modification. So it's like you sit in front of the class. When we done the study, we found most of them just like didn't go with a hearing aid or anything. They were happy in the class, sitting in front, and life continues. Okay, it's not the end of the world for them. Okay. Other bone conduction, anyone saw this one before? Adhere. Bone adhere. It's similar to bone conduction sound arc, but it's attaching with a plaster, like adhesive. A lot of complications. It keeps falling and it's rubbish.
a lot of breakages. That's what patients complain.
Exactly.
It just fell also.
Also, yeah.
Exactly. Because it gets weight.
The equipment to move.
And then you have the bar, okay, with the abutment. And by the way, do you know how to manage if the skin is overgrowing on the abutment? Because I kept asking this question, no one was answering it properly. In the course.
Cut it out.
Cut it or position it underneath the abutment or circulated cauterization. Everyone was saying, remove the abutment, remove the abutment. Why? Just try first removing the skin, repositioning, cauterization, and if it didn't work, remove it.
You can put an umbilical tape as well in like.
You can, just put it back and put the clip to keep the skin in place. Okay. Anyone knows what is that?
Sound bridge. Bone bridge.
Bone bridge. Okay, because I don't know why they choose the similar name. This is a bone bridge. I think it's just Mr. Chagan who's using it in the hoodie, okay? Okay, because it gives you 40 decibels, so it's just like moderate hearing loss, and the MRI shadow is massive, is absolutely massive. It closed the whole, almost half of the brain for 40 decibel. If you're gonna need something for 40 decibel, just give them Baha.
Yeah.
And with the super Baha, Baha 6, it can up to 60 decibel. I mean 6 decibel sensory neural hearing loss, or the other ear as well, up to 60 hearing loss. Baha can be used for both conductive and sensory neural hearing loss. Okay, 60 decibel in both. Okay, bone bridge 40 decibel in both ears, or if whatever decibel in the bad ear regarding the other ear is fine. Okay.
I really don't see the point of that.
Exactly. Bone bridge, no one using it. Yeah, okay, except Mr. Stragan. What is that?
It's a new one, I think. It's under the skin.
Yeah, what kind of device is that? No, not no.
Okay.
Baha connect. No. That's an Osia. 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 So it's the new cochlear device to compete with Medel. Okay, so this is like a new, and it's supposed to be less MRI shadow and more power. I think it can reach up to 50-ish, like pushing it. The company was saying 50-ish. Okay, and you don't have the skin complication from the Baha, and it's under the skin, and the abutment is small. starting last year to do it. We done like 2
I mean,
cases in
Will
UCLH.
this be sort of like a magnetic thing or?
Yes, Yes. Yeah. So this is underneath the skin, and
Okay.
just this one on top of it.
Who's the
Okay. So Baha Connect is from cochlea, and it's massive, and it's 40 decibel. So Baha,
One shadow is more, like this
it's
shadow is
massive,
more.
and almost like bone bridge from cochlea.
Okay.
Bone bridge is Medel bone bridge.
Mm.
Baha Connect is the cochlea device. Okay,
And Oscar is a different company.
is cochlea.
Oh,
So
this is
it's-
cochlea.
yeah. So
Okay.
now the
Cochlea is
promoting
going to
as
this,
the new.
okay.
They're not gonna do Connect anymore.
Mm.
So it's gonna be Ossia is the new thing. So we'll see how it's gonna go. And what is that?
There's a vibrant sound.
Vibrant Sound Bridge. Anyone saw Vibrant Sound Bridge before? Okay. So it's peculiar because it improve the hearing in the defected ear. All the other options transmit the sounds by bone to the other side, but this device, Sound Bridge, will improve the hearing in the same ear. It's like it's a bridge between all these bone conduction devices and cochlear implant. So it's in the range of like 80s or 75-ish. Okay, you all guys, the criteria for cochlear implants. The criteria for cochlear implants. The
The criteria.
the criteria.
Yeah.
Yeah, you know it on the back of your mind.
Bilateral more than 90 decibel.
80.
No, I think.
80 is it?
Yeah, change it.
They have changed, I think.
You need 2 frequencies in both ears touching the 80, okay, between 500 hertz and 4 kilohertz, okay. Plus, this is the audiometric criteria. Plus, no benefit from hearing aid. How we define benefit from hearing aid in adults? Arthropothroid, not BKB. Arthropothroid less than 50. Okay, so that means he's not getting any benefit. And in children, the language development and speech according to the age means they're not getting benefit. Okay, so even if the hearing is like good in the 500 hertz and 1 kilohertz and then dying, okay, is still eligible for cochlear implants. Okay, 75-ish. Now doing the coach trial. Okay, but some centers will push it. If 1 in 80, 1 in 75 in one ear, can push it. Back to sound bridge. So sound bridge, it's like get like a coupler attached to the ossicles. You have different couplers. You have the one attaching to the short process incus, which is the easiest. Okay, you can get one attaching to the longer process of the incus. You can get the one attached to the stapes. You will have to do posterior tympanotomy to reach that. Okay, and you get the one attached to the round window. So even if you don't have ossicles and you want to do vibrant sound bridge, you can attach it, like glue it into the round window, okay, and try to put like a cartridge in the posterior tympanotomy or something to push the sounds through the round window. Okay, difficult, but it can be done. In adults,
So that's only for the conductive loss. Is it?
or since you're even, since you're too loud.
Who is it there?
Thought it's you.
Is it Ayaz?
Well, your bat
I-
signal's up.
Ayaz Habib?
Oh.
We
Oh, there's an H.
Oh, that
Okay,
could be
I think
us.
it's not me. Okay.
Don't thought it's you.
Maybe it's Mrs. Tan.
No, I didn't send.
Oh, you didn't send it.
Maybe Han. I don't know who's the H, and she's not talking.
Is there attendance? Then it's me.
So, in adults managing, if they don't want anything, always remember doing nothing is an option. Okay, can be the best strategy. In the exam, they were asking me a patient with a cancer, massive, and I said radiotherapy, surgery, and he said what next? And I could chemotherapy. I had her with everything, and he said, what else? I said everything. I said, doing nothing. If the patient doesn't want anything, just like leave her alone.
Yeah.
Yeah. We are doctors, and it's like we have that work bias. We need to do something. Like goalkeepers, when they're shooting a penalty, you have to jump to the right or left. If you can't stay in the middle, it's still not a chance to catch the ball. So remember, doing nothing can be an option. If the patient doesn't want anything, just rely on the other ear, and it can be managed.
Mr. Bem has a couple of patients with papillary carcinoma with thyroid.
Hmm.
They didn't want any operation.
Yeah.
They're okay 4 years, 5 years down the list.
It's up to them. Remember, it's doing nothing can be an option. Hearing it. This is the open fit mold. So I wanted to know this is the open fit mold. Okay. So yeah, it's less infection than the custom fit mold because you have ventilation. So yeah, if you have a patient with like a perforation or something, it's better to use the open fit mold than the custom fit mold. Okay, and less gain with this one because the sound can easily escape and cause a feedback. Okay, so the custom fit, if the hearing loss is bad, you need a custom fit mold. Okay, and of course, all the inside the ear and these rubbish stuff is for mild to moderate hearing loss. Cochlear implants in adults, you get how many cochlear implants?
Only one.
Only one. Why?
Because they're post-lingual. They already.
Why you give him one? I thought I asked the question and said immediately someone will
I think
answer.
the only NHS, it's only an.
But it's budget. Yeah, because it's expensive. It's 50,000 per device plus the
How
expenses.
much? 50,000?
50,000. Okay, and you can get a discount on the second one, but it's 50,000 per device. Okay, how you get a second one? How you gonna get a second one?
You have to pay from one pocket.
You can get it from your own pocket. What else? What?
Socials.
What about if the patient works in a environment where needs sound localization?
Doesn't matter.
If the
Still-
first one fails.
You're gonna replace it with another with just one. Ron, this is a question for you. When do you get two cochlear implants? You said if you wait for it.
I know, it's under 18 years and if the patient is blind.
If the patient have other comorbidities, you get. What is the third option? No, you get it. If you complain to the company, and it's actual story.
Yes.
One of the patients had a cochlear implant. We call it V1 failure with the Sonova Advanced Bionic. It was leaking water inside the implant, and most of them had to be revised. So she went, I think, into Switzerland and complained into Sonova headquarters. So they gave her a second implant for free. Yeah, that's a true story. They gave her, she came back to UK. Anyone to implant me now? I got the second implant. Can someone put it in me? That's a true story. But she was so rude patients. Okay. Disadvantage of cochlear implants? I asked this question in the course and no one was like answering. But on hearing, what the problem with cochlear implants on the hearing? How are we going to counsel the patient getting cochlear implants about their hearing?
It won't be like normal hearing.
It will not be like normal hearing, so we destroy the normal hearing. We try to preserve it, giving them the hybrid or soft surgery. Most likely, they will lose the natural hearing. The acoustic hearing would be lost and replaced by the electrical hearing of cochlear implants. And the brain is amazing. The capabilities of the brain in interpreting and transforming the electrical signals that they receive from the cochlear implants into actual acoustic signal is amazing. Patients, that's why are willing to pay 50,000 to get the second implant because it's transformational. It changed their life. Okay, and how's the brain capability? That's why also you need to factor the patient age. If someone like 92, 95, like their brain ability to get benefit from the cochlear implants and transform the electrical signal, the acoustic signals, you have to consider that into your decision making. Okay, patient with learning disability also would be difficult, and that's why when a patient fails Sonova Advanced Bionic, they need to get Sonova Advanced Bionic. You can't give them like cochlear because it's different language there. You have to learn from the start. Your brain will have to start learning a different language, totally different language. Okay, so hearing can be lost, and the balance because we're opening the labyrinth, we're drilling into the cochlea. So there's a risk of balance. You have to see if there any dizziness or any problem with the balance before you put the implants. Plus the rest of the complication of the implants, ictal migration, tip fold over, failure, meningitis. Don't forget meningitis. Give them meningitis vaccine. Extrusion of the implant itself, infection. All these can happen. I was taking too much rice. I got excited. Any question?
One thing, for the evaluation of hearing,
Mhm.
is there any scope of doing ASSR in children to know the threshold?
ASR.
ASSR, have you heard of it?
ASR.
It's sort of an objective, not a subjective test, it's an objective test.
It's the Latin CERR, right? CERR, right?
ASS, I think, yes.
I think they done in.
Usually being done.
Usually we do ABR,
Mm.
but if the ABR is not possible, then they do it. I've forgotten specifications, but if ABR is
Steady
not,
state response, huh?
Augmented steady state, already say, already say.
Don't know.
It can sort of measure the threshold.
Measure the thresholds. Okay, maybe.
I don't know.
I will have to check with it.
Always,
Yeah.
Is there any role of speech discrimination test or speech exception threshold? Is there any role of that one?
In children.
In children or adults?
In adults, so we use the autosclerosis. In American, use the autosclerosis. Just to give them idea if there's also they will get
Okay.
benefit from the operation or not.
speech testimony score, it should be above 75.
Exactly.
Otherwise, won't be able to discriminate.
Exactly. And then you can do cochlear implants in some cases of autosclerosis. But do you know what kind of cochlear implants you will use in autosclerosis? Which one?
Something stronger.
Hearing trigger.
No, this is the problem. If you use something stronger, the current will transfer through the otosclerotic focus into the facial nerve.
Okay.
So with the cochlear implants, you have, imagine this is the modulus. This is medial, this is lateral. Okay, you'll see. So you can put the electrode. You have two types of electrodes. The one that perimodular goes in hugging the modulus. Okay, and you have the lateral wall one. Okay. So with the perimodular, the advantage it's a bit away from the stimulation of the facial nerve. So you get less extra acoustic stimulation with the perimodular. So that's the one that you're going to use an autoacoustic emission. The problem with it is like you're hugging the modulus.
Okay.
So it's the advantage of the lateral wall implants. Imagine like you're in a dark room, okay, and you're holding like a light. The farther you get away from the wall, the more coverage that you have. Okay, so the channels of the cochlear implant can cover more frequencies with the lateral wall. The more that you get into the wall, the more intense is the signal and the less coverage. So we prefer more coverage than less coverage with more intensity, and because you can play with the intensity. Other things they can still now. Medel is getting a new electrode lateral wall, but at the same time they discovered that with each signal, it's slightly complicated. So if you want to shut your brain down and don't okay, there's each current is anode and cathode. Okay, so they discovered that the anodic is the more extra cochlear stimulation than the cathodic one.
Okay.
So they're trying to do cathode and then small anode and then another cathode. We call triphasic stimulation. So they're covering the anode between two cathodes. Okay, so they don't stimulate the nerve much. So you get lateral wall with less extra cochlear stimulation. Still under trial to see how it's gonna work.
So which case of autosclerosis would you go for this
If you
implant?
cochlear autosclerosis, if speech discrimination is gone, okay. If it's like sometimes you do, and it happens. That's why they scare from autosclerosis. Like someone like a registrar or even consultant and complete loss of hearing.
Okay, yeah.
Okay. If total hearing loss with autosclerosis surgery, go for cochlear implant.
Especially if it's bilateral.
Or bilateral. Of course, other than you have to be bilateral. Other than that,
Yeah,
you use other
yeah.
bone conduction devices or these stuff. You can use them. If it's like bilateral, and we done some of them. Yeah, had to cochlear implants because they're strong. Hearing is gone. It's
For ANSD,
ANSD. Oh, it's interesting. So ANSD, you can cochlear implant them. You know what's ANSD? Auditory neuropathic spectrum disorders. Means that the connection in the nerve may be not working, or the transmission is not working, or the brain is not working. And the more signal that you give is like you're trying to push more amplifications. Cochlear implants can work in these patients, can do the medial wall or the perimedular wall, okay, to give more intensity of signals to the modulus to get into to pass the synapse, try to push more signals into the synapse. And the problem with it, you have to tell the patients it's unpredictable. You never know what they will end up because you just give the sounds and you never know. And even with the cochlear implants, I can give you the sounds, you can hear the sounds, but I can't guarantee that you'll understand it. So if I'm talking to you in Chinese, you're not going to be understand what I'm saying. You still can hear me, but you can't tell what I'm saying. So with cochlear implants, it's also depend on the brain of the patients, how it's going to be able to get benefit from the cochlear implant. That's why if it's a post-lingual like 5 years or after 5 years, it's not benefit from it. We took 20 minutes extra. Thank you. Oh, really? It was just like talking about it. If you want to crack on, 2 minutes.
I'll have to go to it.
Okay, so intravenous stem implants, that's interesting subject. I was asking in the course about the intravenous stem implants. So if you don't have a nerve, it's better than nothing.
Yeah.
Do you know what's the advantage of cochlear implants over the venous stem implants? I was asking the question and I think you just answered. Okay, it's like,
It directly stimulates brain bypass.
no. One word. One word. Cochlear implants over venous stem implants. No. One word.
Completely inside. I don't know about it though.
Topographic. Our cochlea is divided into frequencies, and we can stimulate each frequency. We know that the low frequency are the bottom. Sorry, in the top, high frequency are on the bottom. The electrode is
That's what I meant, and I wanted to say was speech like that depends on frequency of sound.
exactly topographic representation of the cochlea. But in the brainstem, you don't know which nuclei is for which. You just like giving everything and pick up whatever you want. So better than nothing. That's the word I use with the brainstem implants. Better than nothing. You get to that option when you don't have any other choice. When you're gonna put brainstem implants? We said on nerve. Second. I asked this question in the course and no one was.
In case of bilateral
Exactly.
neuro.
When you get that. That's the indications. If you don't have a cochlea or swell, bilateral cochlear agenesis, when you're gonna put it, or like the cochlea is the no nerve, or totally ossified cochlea, or bilateral vestibular schwannomas. Thank you.
Okay.